the community-based adult services branch here at the Department of Aging, and I'm very happy to be here to share this approved waiver document with you today. So if we can go, we have presenters in the room, and I'd like to ask them to introduce themselves before we get started. Laura?
This is Laura Conley with the Department of Aging, and we were just talking as we came into the room that before we launch into implementation, we all need to take a virtual high five and congratulate ourselves for having come to this point. We got the word that the CMS had approved the waiver just before Thanksgiving, so we're really, really excited about that. And again, just want to express our appreciation for many of you who've gone through the stakeholder process with us last year, and we know we'll be with it as we move into the transition and implementation phase, which we'll talk about during this webinar. So high five to all of you.
And this is Ed Long, Deputy Director here at California Department of Aging, and I'd just like to echo Laura's comments. Congratulations to us all. The stakeholder process was rich and engaging and resulted in a great deal of input that was very well taken into the waiver amendment. So we're very pleased to be at this point, and we look forward to working with you going forward, and we'll talk about that a little further when we get into our presentation today.
This is John Shen from Department of Healthcare Services. Likewise, I want to echo what Laura and Ed has just said. Thank you for everybody for a very exemplary stakeholder process. I think in the Department of Healthcare Services, when we say we should do a stakeholder process, everybody say we should do it like the CBAS process. And so definitely there's many things that we can learn from that process, but I want to congratulate everybody here, particularly you who are providing care to our consumers, that the CBAS program will continue.
This is Jeannie Smalley with Long-Term Care CBAS program, and I too am just totally pleased that we've gotten the waiver amendment approved, and we're ready to go and move on to the next process that lies in front of us. So it's been a pleasure working with everybody, and we look forward to the days ahead.
All right, Denise Beach again. Let's start with the agenda for today, what we have planned. So first up, we're going to do kind of a high-level summary of the substantive changes that happened. The June document that we submitted that was the result of the stakeholder process went forward to CMS. We've been back and forth many times answering questions and responding to their comments and issues. And today we want to share in the beginning here the substantive changes that have happened through that process. Then we want to walk through the waiver amendment documents, the special terms and conditions, and the standards of participation. We've highlighted those documents with areas that we think are of general interest. And then we've highlighted the changes also that happened during the negotiation process with CMS. So we'll walk through both of those documents. We'll spend some time answering your questions, and we have until 4:30. If we answer all the questions and wrap up before then, that would be just fine. But we have until 4:30 to do that. Our objectives for today. One, to share the amendment document that was approved by CMS with all of you, and then to discuss the implications for changes for providers, for plans, and for beneficiaries. I wanted to add just a couple things at this point for those of you who are new to this discussion. This document represents the agreement between CMS and the state about how the CBAS benefit is to be administered. So that's what we're talking about today, that agreement. And then as far as the implications for these changes that are in the documents, I wanted to just emphasize that we received the approval. Actually, we thought it was coming down. We were pretty sure it was coming down before the Thanksgiving holiday, but the actual approval didn't come till Friday. So that's my caveat about how much more work we need to do in reading through the document, identifying any need for further guidance to both the plans and to providers, and then developing a plan for how we'll get that out through all center letters, all plan letters if necessary. and updating our website. So today is the beginning of the discussion, but we're happy to be here to share the document with you today. So just a quick snapshot for those of you who've been with us through this process all along. You'll recognize this timeline. We updated it to reflect some of the more recent things that have happened, but we started this process back in October of 2013, started the planning for it. Before that, we went through the stakeholder work group process and development of the document through April. May, we had a document out for public comment. And then in June, we submitted the draft amendment to CMS, and we've been back and forth with them ever since. We had a tentative, we had an expiration date on the original CBAS provisions of August 31st of 2014, when it was clear that we weren't going to make that date because we still had a lot more discussion to have between CMS and DHCS CDA. We had our first waiver extension in August, and then we had a second one in October that brought us through November 30th, and then we had the approval that came down on November 28th, which we've shared with all the stakeholder groups via our distribution lists and various other means of communicating. So November 28th, we got the actual approval for this waiver amendment, which is effective as of December 1st. So next slide. So now I'd like to start a summary of the amendment, the substantive changes to the documents since we submitted in June. And so let's walk through some of those, and then we'll spend some time in the actual documents looking at the language. So first up, for special terms and condition number 95. The title of this STC is CBAS Eligibility and Delivery System, and under this STC we have language regarding who's eligible for CBAS and the availability of those services through managed care and through fee-for-service. There were significant changes here in this section with the addition of language by CMS regarding the home and community-based settings services rule. Actually, that's a typo. It's the home and community-based services rule addressing home and community-based settings. And the expectation that the state conduct a CBAS stakeholder process, sound familiar, to develop a CBAS transition plan for compliance with new home and community-based services federal regulations. So this was a big addition, and it came fairly late in the process, so we have a lot to think through and share today. We'll walk through the language when we look at the document, and we also have in the slides, at the end of the slide deck, there's a preliminary framework for that stakeholder process that we have quickly put together here to address this. So that was a big last-minute addition to this STC 95, as well as language that was restored that was in the prior waiver provisions for grievances, appeals, and unbundled services. So those were all fairly significant changes, and we'll walk through the language in a bit. Wanted to add there also that this addition of this CBAS requirement is something that CMS is adding to all states and all waivers. So this isn't unique, something unique to California. The next STC number 96, title is CBAS Benefit and Individual Plan of Care. This STC addresses CBAS required and additional services, all the same program requirements for all of the CBAS ADHC model services and the individual plan of care addressed here. The significant change here was language added, again, reflecting the HCBS rule. CMS added language regarding protocols for person-centered planning that will be developed through that CBAS stakeholder process that's specified in STC 95. And that will be this person-centered planning process to be incorporated into a revised individual plan of care. And we'll have more slides on that at the end of this presentation. STC 97, we have CBAS provider specifications here. STC addresses CBAS required staffing and references provider requirements in the CBAS standards of participation. Language is added here by CMS to revise to reference and incorporate the CBAS standards of participation as attachment W in the waiver itself, and specify that any future changes to the SOPs must be approved by CMS. So that was a pretty significant change in that the standards of participation, which previously weren't incorporated into the 1115 waiver document itself, have now been incorporated as an appendix. STC 98, this title is Responsibilities of Managed Care Plans for the CBAS benefit. This STC is, it was new. This was something that came out of the stakeholder process, a significant new addition of managed care plan responsibilities for the CBAS benefit, including contracting and coordinating with providers and service authorization timelines. And there were no substantive changes made to this section. When we walk through the document, we will highlight some of the more important things for everyone to be aware of. STC 99, title CBAS Central Provider Oversight, Monitoring, and Reporting. This STC addresses state responsibilities. This is about the state's responsibilities for monitoring CBAS provider compliance with program standards with regards to access to services and program reporting activities. And CMS had restored some language here regarding those monitoring and reporting requirements, things specifically around CBAS center capacity and utilization, use of capacity for unbundled services, complaints, grievances, and appeals. So very substantive restoring of language that was in the previously approved waiver that we deleted through the stakeholder process, and with the submission in June that CMS restored into this version of the amendment. And STC 100, the title here, CBAS Quality Assurance and Improvement Strategy. The content here of this STC is that the state has responsibility for assuring health and safety of Medi-Cal beneficiaries receiving CBAS, provider adherence to state licensure and certification requirements, and ensuring that the state meets requirements under 42 of the Code of Federal Regulations for their quality strategy, and no substantive changes were made to this section. STC 101 is titled CBAS Provider Reimbursement. This STC addresses CBAS reimbursement on a per diem basis under fee-for-service and alternative methodologies under managed care, including the options of acuity-based and incentive payments. CMS added some language in this section requiring managed care plan reimbursement to be at a level sufficient to maintain providers to deliver services at the capacity that was available when CBAS began back in April of 2012. So that was the addition there. So that's the sort of high-level summary of the substantive changes there to the STCs. And to the SOPs, not much change here. Lots of things that we want to highlight when we walk through the documents. But the SOPs just in general address the standards for providers, including adherence to all applicable licensing and certification laws and regulations that address center services, staffing, facility, participant eligibility, delivery of care for the individual plan of care, and organization and administration. So there was there were a couple of minor changes here, but the most significant one was that the language was revised under SOP-C to remove the reference to the state provider bulletin authority and to clarify that any CBAS SOP revisions require CMS approval. So that's the high level on all the STC and SOP changes during the last several months since we last left off discussion with all of you in June of 2014. And so now if we can do a walkthrough, we can start with, unless somebody wants to add something to that high level, and then we'll certainly have things to add as we walk through the language. The STCs? Yeah. So some things I want to point out here, a couple of things I did not mention before that that the entire waiver document will be posted on the DHCS website. We understand that'll be sometime this afternoon. On the CBA website, we have already posted the excerpts that begin right here on page 66 of the 618-page waiver document. And so we have the excerpts that apply just to CBAS, and the now attachment W for the SOPs are posted on the CBA website. So this is the beginning of the CBAS section, which begins at section 95, STC. And Jeannie, didn't you want to say something right here as we look at that number, that letter D?
At the B.
D. Yeah. About the technical changes.
Oh, yes. We have 30 days to submit technical changes to CMS. So we will be going through and such things as the enhanced case management, which was eliminated on August 31st. Those references are in the document in various places in the 618 pages. So those will be eliminated along with other technical changes that weren't caught during this process. So we have 30 days to get those into CMS, and those changes will take place.
So just technical, nothing substantive. Right. Okay. All right. So starting with STC 95, again, the CBAS section is 95 through 101, and it begins on page 66 of the big document. Excerpts on the CBA website. So here's the section that addresses eligibility and delivery system. So what we've done is we've highlighted in yellow here, very bright. Sorry about that. Couldn't get any less bright colors on the Word document there. In yellow, we've highlighted things that we think that people should be paying attention to and be interested in, and in blue are the CMS, the changes through the CMS negotiations during the last several months. So there are lots of other things to be interested in here, but things that we want to highlight today in yellow and blue. So under delivery system here, just to address the issue that this is where the benefit is defined in counties that had CBAS on April 1st, 2012. When we converted the program from ADHC to CBAS. So that's when CBAS was born. And then there's that next sentence that addresses where CBAS wasn't on April 1st, 2012. There are provisions here for it being available. And so the references here, it references over to section 98, STC 98, and we have that highlighted as well. But again, it specifies under what terms the benefit is available in areas other than where it was in April of 2012, and we'll talk about a little bit later about some of the things that are underway in developing processes for new CBAS center, for prospective new providers. In the blue there, CMS added the state must ensure that plans have mechanisms to provide care coordination, person-centered planning, continuity of care, out-of-network care, and other provisions related to newly enrolled managed care beneficiaries as described in STC 85F. So CMS showing a concern for ensuring that we have care coordination and person-centered planning, continuity of care, issues that are common themes that have been throughout, especially throughout the CCI transition. Do they have anything to add there?
Okay. Obviously, STC 85F is something further back in the document, not
right.
Specific to CBAS,
right.
But relevant to the 1115 waiver overall.
Correct. And so that's available if you follow the link on the CDA website when the DHCS has it up and posted, where we look at the entire 618-page document and find that 85F. Okay? This area highlighted here, it represents the restoring of the unbundled services benefit, which we had deleted in the version submitted in June of 2014, and CMS has restored that language.
You want to talk to that?
No. So not much further. There's a lot of detail in that, and again, that was what was in the previously approved waiver. Under C there, home and community-based settings, this is where we were sharing the substantive change that CMS added with regards to the state ensuring that the CBAS providers meet these new rules. Just to read through it, that the state has to ensure that home and community-based settings, and that includes CBAS, have all of the qualities required by this federal rule listed there, and other such qualities as the Secretary of Health and Human Services agency determines to be appropriate based on the needs of the individual, as indicated in their person-centered plan, in a provider-owned or controlled setting. Additional qualities required. Again, they give the citation there. More information, obviously, we're going to be sharing in coming days about this. The state will engage in a CBAS stakeholder process to amend the HCB settings statewide transition plan. So that's a plan already underway. DHCS is working with other 1915 waivers to get a transition plan together. CBAS will start its stakeholder process in early next year, and then we will be amending the statewide plan with the CBAS plan added to it. So, and it lists right there that it will be no later than September 1, 2015 to ensure compliance with the rule, which allows the plan, the states to have until March of 2019 to fully come into compliance. So we'll be working on getting the CBAS plan together beginning in the early 2015. Okay, moving on. Under eligibility determination, we highlighted here, again, for those of you who are new to this discussion, regarding the face-to-face reviews that are required for eligibility. The standard requirement, default requirement, is that initial eligibility determination by the plans it is done via a face-to-face determination. And this item now allows for the managed care plan to determine, based on its knowledge of the member and data and information it possesses, to waive that initial face-to-face to make someone eligible. Not to make someone ineligible. Denial can only happen through a face-to-face, but the initial may be waived by the plan under certain circumstances, and this now addresses that. The second item that's highlighted there under number 3, eligibility for ongoing receipt of CBAS is determined at least every 6 months. That's the regulatory standard through a reauthorization process, but this allows for an up to 12-month authorization for individuals, again, determined by the plan to be clinically appropriate. So this is a significant change that came out of the stakeholder process and is now memorialized in this document. The next section, F, grievances and appeals. This was language, actually the first one there is what was in what we submitted. CMS added back in section 2 that has the CBAS participant grievance, further elaboration on what that process is. So, so they just added back in previous language that we had taken. Do we have questions coming in? Should we stop and answer some questions, or do we want to just handle them all at the end? You're handling some of them at the end?
Handle them.
Yeah, okay. All right, so individual plan of care. Again, this is where we covered in the slides earlier. CMS added into the section that already addressed the individual plan of care, the person-centered planning process that will be defined in the through the CBAS stakeholder process that we're going to be undertaking. And this will be incorporated into the plan revisions as of September 1st, 2015, no later than, and that will specify how we're going to comply with those new federal rules regarding person-centered planning, how the plan will identify each enrollee's preferences, choices, and abilities, and the strategies to address those preferences, choices, and abilities. And the plan in this case refers to the individual plan of care, not the health plan, just for clarification. How the plan will allow the enrollee to participate in the process of planning their treatment, including the opportunity to involve their the people that they request, and how the plan will ensure the enrollee has informed choices about treatment, how the planning process will be collaborative and recurring and involve ongoing commitment to the enrollee. So new things that we need to be looking at for person-centered planning, incorporating that into our current processes, many of which CBAS ADHD providers are already familiar with. through our individualized processes, but that will memorialize further through these requirements. And this is the addition under Section 97 for provider specifications. The state Medicaid agency maintains standards of participation for all CBAS providers are found in Attachment W. So that's the SOPs, again, being incorporated now into this 1115 document. If you pull up the big document, the 618-page document, you scroll to the end, Attachment W is the last attachment to that document, so you'll see it right there. Instead of having to find it just on the website. It's formalized into the waiver. Under 98, we have this is the brand new section that refers to the managed care plan's responsibilities for CBAS benefits. And all of this is brand new to the STC for STCs for CBAS. Highlighted this because it echoes back to the STC 95, defining sort of how the network for CBAS providers for the plans is defined. Plans may but are not obligated to contract with CBAS providers, and these are the CBAS providers that were basically in CBAS as of April 1 at the time of the program's beginnings. But the plans aren't obligated to develop new CBAS networks. So it's an optional thing if they choose to develop additional centers, but there will be provisions forthcoming about new potential CBAS centers around the state. So I want to make you aware of that highlighted section there. The next highlighted section, again, this is what I think we have referred to during the stakeholder process and other discussions as selected contracting on the part of the managed care plans. So the managed care plan may exclude any CBAS provider to the extent that the managed care plan and CBAS provider cannot agree to terms. The CBAS provider does not meet the plan's credentialing or quality standards, is terminated pursuant to the terms of the CBAS provider's contract, or otherwise ceases its operations. So in our previous provisions, we had managed care plans being required to contract with all willing providers. And this represents a significant change. Also in this section 98, the eligibility and authorization, wanted to highlight that where we talked about the plans having provisions to waive the face-to-face if someone is clinically appropriate, or to determine that an individual can have a 12-month authorized TAR, that's now an option. But that the plans need to develop policies and procedures around that to address what those processes for authorization and eligibility will look like. Next up, just want to again highlight the continuity of care theme, which is in this section and throughout the waiver document. If you can scroll back up, yeah, oh, there we go. The managed care plan shall ensure continuity of care when members switch health plans and/or transfer from one CBAS center to another. So that next piece under Section C, where there's coordination as a theme. Again, the theme being ensuring that individuals get the services that they need in a timely way, and that when there are changes from plan to plan or center to center, that there's coordination among the providers and between the providers and the managed care plans to ensure that individuals' needs are met. Also, in development of the IPCs for those individuals, more emphasis on coordination between the plans and the providers, and exchange of information. Reports of incidents, and we're going to talk about that a little bit when we talk about the SOPs, but incidents and discharge, the need for communicating that back and forth between plans and providers. Clear communication pathways so that the providers and plans know who they're working with to do this coordination. And then the last item, written notification of plan policy and procedure changes, and a process to provide education and training for providers regarding substantive changes that may be implemented prior to the policy and procedure changes taking effect. So ensuring that the plans meet responsibilities regarding communicating changes with their contracting providers that the providers need to be aware of in order to deliver the services to their members.
I want to mention that it's not the IPC that's 12 months. It's the on-rate.
Yeah, good point. So with regards to the IBC, and I think we're going to be working at CDA to get more clarification to providers around some of these issues, especially so that there's not confusion between what's a program requirement in regulation and statute and what's a authorization flexibility that the plans have. But in regulation, providers are required to do 6-month reassessment and develop care plans every six months. Now with an authorization for 12 months for an IPC, the provider is still responsible for doing regular quarterly progress and assessment, reassessment notes, and making any revisions that may be needed, but they're getting authorization for the treatment, not necessarily, that doesn't change the 6-month rotation for reassessments. So cover it? Okay. Under 99, again, we had a number of things added back in by CMS with regards to the state's responsibility for reporting, and lots here for us to wade through. I can tell you we have not entirely made our way through all of these items, but many of these are the same items. Some of them slightly revised from the previously approved waiver provisions for reporting. And under Section 101, that last addition under the reimbursement, the reimbursement rate in this one that probably everybody's familiar with, should have probably highlighted this in yellow, that essentially the fee-for-service rate is published. It's the same per diem rate structure that has been in place for a long time. The managed care plans under this STC now have the flexibility to either go with the all-inclusive per diem rate as it's being done now, or to have alternative methodologies for payment. So CMS added in this provision: plan payments must be sufficient to enlist enough providers so that care and services are available under the plan, at least to the extent that such care and services were available as of April 1. So some insurance policy there that that the plans are making sure that they have adequate number of providers and that the payment is commensurate to insurance. So that's the walkthrough of the STCs and walkthrough of the standards of participation. Again, highlighting this beginning section here. Well, first of all, I'll start at the header, attachment W. So this is the last section of the now waiver, so it's been incorporated. The general provider requirements have been revised significantly, not by CMS, but significantly through our stakeholder process. The entire document has been reorganized in a way that we thought made a little bit more sense for the way it rolls out. And the general provider requirements up front have changed significantly. The entire piece that previously referenced the nonprofit only providers, that has been deleted and that provision has been eliminated. And then this introductory section, which refers to the licensure and certification of providers, again, parts were eliminated from the previous document that constrained centers that could be licensed or centers that could be certified for CBAS to those who were licensed as of December of 2011 when the settlement agreement was reached. So those provisions are no longer in place. So we'll be developing a process for allowing application for prospective new CBAS centers. Scrolling down, the next change is what we've already sort of touched on with regards to CMS, eliminating some language around provider bulletin authority for changing the standards of participation. So they want to see any changes to these standards of participation for the providers. They want to see those changes sent to them and that they receive their approval prior to those going into effect. So any changes that we make to this document needs to be submitted to CMS. This highlighted area, subject near and dear to my heart, that providers must have capacity via electronic equipment, including computers and software, adequate to comply with state reporting requirements. All of our reporting requirements are becoming more onerous, and so we want to make sure that we have providers who are able to communicate with us via the electronic means that we need to run the program. So other things to highlight here, there's the reauthorization provisions that are now on the CBAS provider side. Reauthorizations submitted there for 6 months or up to 12 months, and that's again just reflecting that change that's made into the STCs. Under IPCs, again, more language for the providers regarding the IPC being the result of a collaborative process among the CBAS provider, participant, participant's authorized representative, and the managed care plans. Under number 5, this is an important provision. We get questions a lot about the environment now with managed care plans wanting to see authorization requests for CBAS more than 30 days prior to the start of the new services. This causes some challenges for the providers who are used to meeting regulatory requirements for a timely reassessment conducted within 30 days of the start of the IPC. So this provision is an effort to address that. So it says that if a participant is in a Medi-Cal managed care plan and the participant's plan requires submission of the IPC more than 30 days prior to the effective date, the CBAS provider needs to identify any changes in the condition requiring the IPC amendment prior to implementation and amend it according to the change, if a change to the IPC is needed. So, in other words, if your managed care plan partner is asking you for authorization for your IPCs, that they be submitted more than 30 days out, let's say at 45 days, the center does the assessments prior to the 45-day window and then just ensures that once that IPC is going to be implemented, they've done a quick check and ensuring a re-evaluating of that IPC to ensure that no changes have been made prior to it being implemented. So we're trying to address that sort of regulatory and new environment constraint with this provision. Another result of the stakeholder process, a request from providers who have long been challenged by the requirements for therapy hour totals, monthly therapy hours based on average daily attendance. Those are specified in terms of increments of 10 increases in average daily attendance driving an additional 40 therapy hours. So this is just a simple technical change to no change really in the overall volume of services, but to address if you have a change in 5 participants in average daily attendance on that quarterly basis, that you can increase the monthly therapy hours by 20 instead of going up by 40. So kind of a technical fix, but addresses a long-standing sort of regulatory problem there. And this section addresses new reporting requirements from the perspective of the providers. You need to be able to comply with requirements for standards of participation, in these standards of participation for discharge planning, sharing of discharge plans, and incident reports. So what I wanted to highlight here is just that this is formalized now in the standards of participation, and that CDA has been working on developing some standardized formats for reporting to streamline it, streamline the discharge reports, to streamline the incident reports, and to allow for more consistent collection of data. So we'll be talking to you, I hope, releasing those standard formats sometime in January, bringing you a training webinar and helping you to understand those new reporting requirements. And that's everything that we've highlighted. There's a lot more, I think, that we could say that are in these documents that are of interest, and that as you dig through them and have questions, we would expect that you would have more questions, and we'll be asking them on some of them ourselves as we dig through them. But for now, that's the high-level overview, and look forward to more conversations going forward. And now maybe some time to answer some questions. Actually, you know what, before we do that, we have, if you click to the next slide, Lilith, We have, this is where you can find a copy of the slides for today's presentation, where you can find the link to the waiver documents, including the full waiver link over to DHCS's site, and the excerpts for the STCs and SOPs. And then I think, okay, yeah, there it is. Already up, great, thank you. And then if I could just quickly overview, because I know we're going to have questions about it. This slide addresses a it's a preliminary framework for the stakeholder process that we put together quickly here. We need to make some more specific dates, get some more specific dates set up here. But this is generally the process that we're going to follow to address the requirements that CMS put into STC 95 and STC 96 regarding coming into compliance with the new home and community-based services rule, the new federal rule. So basically, this outlines, what we're going to do, who's going to participate, where we're going to do these things, have these meetings. If you drop down to the anticipated stakeholder process timeline box, we have 3 meetings identified beginning in February to start our discussion, March to identify some planned components, tasks, and timelines, April to continue with that process and developing the components, and in May to share a draft transition plan and open a 30-day public comment period. These are the requirements that we're going to need to meet. We're going to go back and incorporate changes and then have another stakeholder input process that kicks off in July. So we'll share the document again that's been revised, a 30-day comment period, and then we will prepare to submit to CMS on September 1st. So that's sort of the general framework that we've laid out for the process needed to identify how CBAS will be brought into compliance with this new federal rule over the next 5 years. And this is just just to let people know, we've been communicating with our stakeholders that signed up through this Department of Aging's stakeholder distribution list for some time now via our emails, and we have a new format that we've gone to. We sent one out last week or a couple weeks ago to our CBAS providers and to all folks who were on that distribution list. We wanted to let you know that we're going to continue to share information in this format. We like the new view, and I think it's going to give us some flexibility for getting good information out to all of our people who are interested in the CBAS program. So we're going to automatically distribute this to providers, so you don't need to sign up, and because we're going to send it to you anyways. And we'll continue to send information to providers, obviously, through our all center letter process as well for more substantive issues. And then the CBAS distribution list, we're going to be discontinuing use of that. So if you want to sign up for getting regular updates, then you need to follow that link that's right there and sign up for getting the distribution of this little new news format from us. All right, and now I think that brings us to questions and answers.
I think some of the questions have been geared around unbundled services and how people bill for unbundled services, if it's through a center. So I think we need to clarify that the unbundled services are for when there's a center closure, and that the unbundled services are the services that you get at a CBAS center, but because there's a center closure and no other CBAS center available, that those would be unbundled services such as physical therapy or physical therapy or occupational therapy, speech therapy, something that would be prescribed IHSS services, something that would be prescribed or the person would get directed to other local service providers for those services. Do you have anything else?
No, I think it's the important point is that the CMS continue to want to make sure that in the event of a CBAS closure, the existing CBAS participants do receive services that is appropriate for the level of care and level of need so that there's continuity of care. And I think we have, in our own stakeholder process, talked about removing that, but CMS feel that is a level of assurance we need to make to the consumer, and we finally agree with that to basically put unbundled services back into the SDC. Okay, so it's really in the context of a CBAS closure, not in the context of CBAS providing other unbundled services out of the four of the CBAS center to other participants that is not CBAS participants.
Another question was on the demonstration approval. The period is from November 2010 until October 31st, 2015. And that is for the entire Bridge to Reform demonstration project waiver, in which you do not want to print the whole document because it's now, like Denise said, 618 pages. And the CBAS portion of that document is about 20 pages. So our amendment is fairly small in that. It will be renewed with the Bridge to Reform waiver as that goes forward. But right now we're just looking at it being amended to go forward past the August 31st, 2014 end date. So we're now into the whole cycle with the Bridge to Reform waiver as that goes forward. But we won't be having stakeholder meetings specific to CBAS. It's just the whole Bridge to Reform waiver that's going forward.
And we don't anticipate any changes to the CBAS provisions during this waiver renewal.
We're very happy. We also had, is there a section that tells us why someone would not be accepted into a CBAS program beyond the ADL issue, such as needs of one, need care beyond the scope of the ADHD program, perhaps a mental health condition that is beyond the training of staff and the scope of ADHD CBAS programs?
So I'm not sure I understand the question, but I guess I direct the person who's asking the question to the eligibility section 95, section 95, and the eligibility criteria under letter D. And those criteria are the same criteria that have been in place since CBAS was born in April 2012. And they have the nursing facility level A as one of the criteria, diagnosed with acquired organic brain injury, mental illness. So there's 5 different sort of categorical areas that cover what you described, as well as the requirements for medical necessity criteria being met. So I think that the answer to that question might be in there. For someone who was more compromised than could have their needs met at a CBAS center, then they would need a higher level of care.
We ended up getting quite a few questions on the difference between the 12-month authorization and the 12 months, the possibility of 12 months of service. And I think we need to be clear that if a plan decides to utilize the 12 months of service, that we need to see that in the policies and procedures for the plan to be revised so that they can make that 12-month determination. But we had some questions on from CBAS providers on how do we determine to ask for 6 to 12 months of service.
Yeah, so I think that, that whole section 98, again, I would encourage everybody to take a close look at what's in that section, and you'll see that that the requirements for plans developing policies around authorization and eligibility that address these new provisions, first they need to do that, and the plans also have a responsibility for communicating with their contractors what it is their policies are, these changes to their plans, and that's specified in that section 98 as well. So, so any changes to the process need to be originated with the managed care plans. So CBAS providers can count on that.
And this was part of the discussion that came out of the stakeholder process with plans wanting a little more flexibility for someone that was on a maintenance type level and going to a center more for a maintenance type level of care, and so they could authorize services for 12 months. Because we did have a question here that said they were referring to CBAS Center's assessment process, which they currently do every 6 months, and would that change to 12 months? And that's what.
Yeah, so the program requirements are still in place, and CDA will be working on getting some further guidance out about this. So I think there's some amount of fleshing this out that we need to do internally, and we'll get some guidance out to providers about continuing compliance with the program requirements. One of the reasons why when I discussed the provisions for the reassessments, for example, being conducted beyond the 30-day window, which is a regulatory requirement, that requirement is still in place. But the intent of that requirement is that that care plan is developed based on the most current identified needs of that individual, and so it's appropriate at the time it's implemented. So we're trying to work with the current program requirements and law and regs, and the reality of the environment you're now operating in with managed care plans. So it's one of those kinds of issues when we talk about a 12-month authorization. The program requirements are still in place. Now we're going to need to make some amount of adjustment, but still meet those program requirements and address the new provisions for 12-month off.
And if there is a change in a standard, since these go into place as of yesterday, how long would plans and providers have to meet new standards?
Okay, so the plans are developing this as an optional thing. So they may not develop it at all. So again, all of us are sort of getting geared up to implement these new provisions. And to many of the plan partners who are, I'm sure, on the line, they're looking at how they might or might not implement these things. So it's going to be voluntary on their part if they see a need to implement these provisions.
How much can how much can a for-profit center owner become involved in program services?
I'm not sure I
We don't
understand
understand the
the
questions.
Because we don't have any changes in for-profit or non-profit.
Somebody, if you want, we can have them send that question to our main mailbox or give one of us a call at the numbers that are listed here, and we'll see if we can help you out with that. Yeah, exactly. There we go.
Will there be an adjustment to payments per participant's condition?
I think that's basically for the fee-for-service, we will publish a rate. That's basically a fixed rate and per day of attendance at the CBAS Center. But for managed care plan, they do have the flexibility. Again, this is optional to the managed care plan. They can continue to follow the department's established rate, or they can adjust the rate based on the level of care, acuity of the individual, and as long as the plan meets the requirement that they can maintain adequate network of CBAS provider for the plan members. So the plan do have the flexibility to set the rate based on the acuity and conditions, but it's again a plan's decision. It's not a Department of Healthcare Services or CMS decision to do that.
Is mental health therapy and psychiatric unbundled?
So all of the services at the CBAS Center that are required services, which include mental health services, those are on the list of required services. And so anything that is provided at the CBAS Center is conceivably a service that can be offered in an unbundled model.
And the unbundled service would be when a center closes and that person still needs the specific service, so that would be prescribed for that person to go and get those services.
That's correct.
Can all existing CBAS stakeholder process participants be included as stakeholders in the new HCBS stakeholder process?
I'm not sure I understand the question, but if the question is if you participated in the CBAS stakeholder process for developing this waiver amendment and you want to participate in the HCBS process, we welcome any and all comers. So I think maybe there was some confusion around our changing of our distribution list information. We've been communicating specifically with people who said they were interested in the waiver amendment process. So we don't want to keep, talking to those same stakeholders. We're asking you to sign up on our website via the link on the slide that I showed you, so that you can get our news updates and that you will see future opportunities to join the CBAS discussions that are forthcoming. We just don't want to keep sending to the same people who've been helping us all along who are interested now in stepping out. And these slides are posted via the link that we showed you also in this slideshow. Oh, actually, you can't access that link via the slides if you don't have the slides. So what we will do after this webinar is we'll send a copy of the slides out to folks who were on the webinar, or access a link so we can get to it.
Just to clarify another unbundled service question, can you provide unbundled services off-site to individuals who do not attend CBAS centers, but may be approved for, let's say, PT or OT? So again, we want to make sure everyone's clear that unbundled services are only for people that are attending a center that is closed and cannot attend another CBAS center in their local area. And then they would be able to get unbundled services as
through their managed care plan.
Through their plan, correct.
Consistent with their plan of care.
Right.
The plan of care.
Yeah. Consistent with their plan of care. And is there any changes R/T therapy hours standards?
Related to therapy hours. So the therapy hour discussion that we had, the change to the standards of participation are that it's a minor change, and it's not to the overall therapy hours. It's just to allow for increases on a monthly basis based on increments of 5 in average daily attendance rather than 10. So it's just kind of it's a technical little fix that addresses a long-standing issue in the regulations that if you increased by 1 in average daily attendance and all of a sudden you had 40 more therapy hours they had to provide in a particular month, it didn't make sense. So we changed that to allow for an increment of 5, upping increasing the hours by 20.
Okay, and another question is, can you say a little more about the requirement on reimbursement? There are currently centers planning for closure due to inadequate reimbursement. Doesn't this requirement have a substantive impact on that issue? How do you expect that provision to be operationalized?
Can we pull the STC 101 back up again and just put it on the screen?
So let me just start that, as most people know, there was a 10% cut for the ADHD centers back in 2011. So that did lower the cost or the reimbursement rate for many centers. So it has been, we know it's been a struggle for many of the CBAS providers over the last couple of years.
So I think the STC 101 say very clearly basically is that there's a fee-for-service rate that DHCS published. That DHCS rate is at this point still affected by AB 97, which have the 10% cut. And as long as AB 97 is in effect, that 10% reduction will still remain in place. In terms of managed care plan contracting, managed care plans do have the flexibility to establish different rate from the rate that DHCS published. Those rates can be based on acuity, can be based on level of care, but that's individual discretion of the managed care plan. And so the plan will be communicating to you in terms of how they would want to set the rate for the CBAS provider or set the rate for different types of consumer in the CBAS who are CBAS participants. But that is absolutely at the discretion and rate setting process of the managed care plan and is not subject to HCS or CMS decision-making process in that. And so when we say, when the question is how the department operationalizes it, we definitely encourage the managed care plan and CBAS provider to have a productive conversation on those kind of issues rather than having anything that the department can influence that decision-making process. And this is true for CBAS as well as true for many managed care services that managed care has to provide. Managed care plans do contract differently from Department of Healthcare Services Medi-Cal rate in their geographical area based on the need of the plan members and based on the situation in that community that they serve. I hope I answered that question.
I think so. What are the changes to the 6-month reassessment and IPC requirements?
Okay, so the changes to there are no changes to the program requirements that are in law or regulations. So same things that have always applied to CBAS providers with regards to doing reassessment of the appropriateness of the plan of care, the progress on the goals that are stated in a plan of care, need for revising those, all of those still are in place. What's changed is the plans will have the discretion to authorize up to 12 months. So, so that doesn't change. It changes the effective period for an IPC, but it doesn't change the provider's responsibility for ensuring that any modifications get made to the IPC if are necessary, and a regular reevaluation of the appropriateness of the goals and whether the goals are being accomplished and need to be revised. So again, I think that we're going to have to get some further guidance out to providers and probably have further discussion with the plans as well as to how this might work. But the expectation is that this will provide will be an improvement for some individuals who don't need as regular authorization of their TARs. But how it gets implemented, I think we have still a lot to explore there.
When can managed care plans begin meetings with CBAS programs to establish a new rate?
It's up to the plan.
And it's what is stated in the contract, the
Yeah.
current contract.
Yeah.
So the current contract would need to be negotiated.
Right.
Any face-to-face rule changes still needed by all beneficiaries?
Okay, so there are changes to, can we scroll up to STC 95 to, let me see, it may not be 95. We'll look at it. So there we go. It's under STC 95, the initial face-to-face review is not required when the managed care plan determines that an individual is eligible. So they basically know that person is eligible to receive CBAS because they are clinically appropriate based on information the plan possesses. The individual is coming through the hospital discharge plan process, or they're being discharged from a nursing facility. Something that the plan already knows about that individual who's applying for CBAS for the first time. They know that they're already eligible, so they're going to waive that face-to-face requirement. So that's the provision for, that's the language that states when the exception can be made to the face-to-face. Otherwise, the initial face-to-face is the default. It's required for determining eligibility unless what's met under item 2 and 3 there it is in place.
Also regarding face-to-face assessments required by the plan, if the CBAS center determines that a participant needs to be discharged in accordance with regulation to ensure the safety of others and the participant or family does not wish to be the person to be discharged, is a face-to-face required?
Yes,
Okay.
that's termination of services, yes.
So there's a couple of things that work in. I'm not sure we fully understand the question, so I'd start with saying we're going to be getting some more clarification around discharge together because we have some issues developing our discharge plan requirements. So first up, the center has policies and procedures that specify when an individual participates. You have a participation agreement that says what the participants' rights are, what their responsibilities are with regards to participation. If that individual becomes a threat to themselves or to others and can't be served in the CBAS Center, that's appropriate cause for discharge. It should be in your policies and procedures if that's the way you operate. Certainly you would coordinate with the managed care plan around those issues. That's a separate discussion from authorization for services. So when you say, John, yes, so the plan has responsibilities with regards to terminating the authorization. So the authorization is a separate piece.
Yes, I understand.
Yeah.
I think that's those two separate issues. So if the plan decided that someone needs to be served differently, undoubtedly the plan needs to involve the consumers and the consumers' significant others in that decision-making process, and in that, at the end of which, if the consumers say we want to go to someplace else, then the plan basically can stop the CBAS services. So those are the kind of process the managed care plan do, but that's different from the regulatory requirement that CBAS need to do when CBAS consider a person unsafe to be in the environment of the CBAS center and discharge, and that also need to be coordinated with the plan. One is a discharge from a CBAS provider based on changing condition of person. One is the health plan initiating a discharge. Two separate issues.
Yeah.
John, do you want to also talk to about the rate cut exceptions that were involved with AB 97 from 2011?
I don't know what I can add to that. Basically, is that we look at the exception. There's only a few exceptions that happened since the rate cut happened, and those exceptions are all based on accessibility of CBAS centers. And so I think the most recent exception would relate to a process that we have gone through with the CBAS Center in San Francisco. We basically look at the impact of closure of multiple providers in their areas, and basically have provide an exemption to San Francisco CBAS centers. So it's a unique to San Francisco situations, which is very similar to some of the exceptions that we have provided in the early days of 2011.
Yeah, some of them were prescribed in the plan for the rate reduction. Some counties were carved out. So I think today we have about 200 of the CBAS providers are in areas where they're subject to the cut, and the other 45 are not.
Another one for John is, what incentives do managed care plans have to increase rates for CBAS centers?
I think this is definitely a conversation between managed care plan and the CBAS center. I think the incentive this has to do with how can managed care plan provide a better service to the consumer, and how can CBAS provider be a service that replaces other costly services. So it's both from the patient quality standpoint as well as from a standpoint of cost avoidance. And so those are the incentives that a managed care plan would probably consider changing their rates for different populations that's their plan members. So, so those are definitely individual discretion of the managed care plan in the geographical area serving the plan members.
We also have a question. When will managed care plans be capitated for CBAS? Do you?
They are what? They are already capitated for CBAS.
And we just had, as of today, December 1st is the last day that the 4 counties, the rural counties, transition so that there are capitated rate for CBAS as well.
Right.
And the, do you know the rate managed care plans will receive for each participant?
I think the rate for managed care plan is not calculated because they're CBAS participants or not CBAS participants. They're calculated from the entire county in terms of the Medi-Cal beneficiary in that county, what is the cost experience in the fee-for-service environment, and CBAS was considered a fee-for-service environment, and that's calculating the rate and it's given to the managed care plan.
Do all clients in CBAS centers in Sacramento County have to be rolled into a managed care plan? So Sacramento County?
Yeah, so CBAS is a benefit in managed care in Sacramento as it is in statewide. Jeannie just talked about the 4 counties. We had 4 counties that were still rural counties that weren't done in CBAS in managed care that as of December 1st are now. But within all of the counties, there are still individuals who have exemptions from enrollment in managed care for one reason or another. There are very few of those exemptions that are going to be remaining in the CCI counties, but there will still be a small population. Right now we have about 2,000 people who are served through fee-for-service in CBAS. And those numbers are going to be going down, down, down as, well actually we've got to revise those already because as of the 4 county transition on the 1st, we probably had about 700 people that came off that list. So we expect to just have a few hundred people remaining fee-for-service. But there may be a few people in Sacramento County who are remaining in fee-for-service.
So CBAS is a managed care benefit, and only a few people will remain in fee-for-service after December 1st and going forward. And those are, like Denise said, are the ones that have exemptions or some other extenuating circumstances by chance. The answer, regarding rates, is there not a requirement that plans pay a sufficient rate to sustain services?
I think the plan has a requirement to pay a rate that their plan member, if they want to access CBAS, there's sufficient CBAS center to serve them.
And that's outlined in 101 here on page 75.
Is there a way to come up with a uniform policy to facilitate the process of moving from one center to another center? The way it's done now is not working, and there are long delays, especially with the LA region.
I think it's an interesting proposition. I mean, to the person who's suggesting that, I think it's something I'd certainly be interested in having them call me and talk to me about. Right now, there's no prescriptive way that we approach this. When we had an all fee-for-service program, we tried to make some transition rules that made sense and that expedited services. But I'm certainly interested in having a conversation about that.
We have another question on the October 2015, the 11/15 expiration date of the entire Bridge to Reform waiver, and just to reiterate that the CBAS is a small portion of that Bridge to Reform waiver, and that will be that's currently being amended and renewed right now. So CBAS will be part of that renewal process, but it will continue on after the October 2015 date. So there's no fear that CBAS will end in 2015. Who determines what sufficient center means when it comes to rate increases?
I think that's definitely a not an easy answer to provide, but basically what we track in terms of network adequacy, we basically look at how long does it take for a CBAS participant in a plan to enroll in a CBAS. If there's a request, if there's a request for CBAS services, if the plan takes longer than what normally is required under the law, then they don't have sufficient centers. So it's not a hard and fast rule, but nevertheless, we do track data from the managed care plan in terms of consumer requests to attend CBAS, going through the entire process to the point when the person is actually enrolled. We have required managed care plan to report those data to us, and those are the kind of information we look at in terms of accessibility.
Is there anything that prevents a plan from reducing their rate? How does a CBAS provider have the power to negotiate rates?
I think that if, as long as the CBAS provider are meeting the need of the consumers, I think these are the conversations that you need to have this managed care plan. But I think that the important thing is for the CBAS provider to remember is basically you're working with a managed care plan who is responsible for the outcome of the care of the plan members. And I think CBAS will be extremely well positioned to take care of their frail individual and help the managed care plan provide community-based care as well as avoiding high-cost nursing home care. As long as you do that, there shouldn't be any concerns about managed care plan artificially reducing rates.
That makes sense.
Some questions on new centers, I think.
Yeah, we have a question on news. What is the, how are we going to, what's the process for opening a new center?
So we are putting finishing touches. We have been waiting for the approval of this waiver amendment to get a document posted on our CDA website. Expect to have that in the next couple of days. That spells out the process for a pre-screening of potential applicants, and we'll have that up, I hope, like I said, this week, and it will describe basically what has to be done in order to ensure that we give applications to individuals who are prepared to make it through this process. One thing is for certain, we can't have an application process like we've had in the past where we have individuals who are coming in and possibly aren't as prepared as they should be for what they're getting into. We want to make sure that we have a process up front before the application that brings that prospective applicant and the managed care plan, contracting, who would be interested in contracting together to make a decision before they move forward with an application. So we've got a process defined, and we just need to get it posted up on our website. So coming soon, an overview of the process, and then we would expect to be able to have applications sometime in early 2015.
Since we're kind of running out of time, do you want to go back, and we had some questions on where they can get the webinar presentation and the links, so maybe you'd want to go back and
sure, if we can bring a copy of it up. And so the webinar slides are posted on our website, as are the excerpts from the huge waiver of the CBAS STCs and the now attachment W for the SOPs. Those are all up on the CDA website, and as well as a link to the big waiver, which is posted over on the DHCS website. So we've got it up on the screen right now. The slide, there's a slide in the slideshow that has the link here, and we will make sure that we mail that to folks after the webinar today, so you have the link to get here. But this is the link right here if you wanted to write it down, and it has all of those documents posted.
any time frame that you think will be used for accepting new applications for CBAS providers?
So the first step, again, I'd encourage everyone to take a look at our website. In a couple of days, we'll have a very clear path to that document describing the pre-screening process, and it will involve a set of defining basically a program plan and having the prospective applicant bring that program plan to a potential managed care plan contractor, share that plan, and basically demonstrate prior to beginning filling out all of the forms and developing the application, a rather large application process. We don't want that to start until we have a prospective applicant who's aware of the environment today and has made a journey into the managed care plans offices and talked to them about whether they are interested in contracting with them before they start the application process. So that's going to be up front in the process, that pre-screening, and it'll be a document posted on the CDA website this week.
Just to clarify, I think there might be some confusion because we had a question of what additional services do rural area CBAS centers provide that makes them earn the full rate, the full fee of service rate? What does an area have to do with the rate amount? And I think there might be confusion because we were talking about the rural counties just getting the managed care rates converted over as of December 1. They were getting the rates just as all throughout the state have been getting the rates paid. They were just a carve out for fee-for-service and not under managed care until December 1st because of implementation of managed care plans in those areas. And that's been completed, so they're now getting the same managed care plans and rates as before, as all the counties with CBAS centers. We did have a question here regarding program. If someone is eligible for CBAS, but the center is not going to, can a CBAS provider accept a client into the program but refuse to provide the transportation service?
So transportation is one of the required services that's provided through CBAS, and it is transportation that is either arranged or provided. So if the individual does not need transportation via a contracted transportation provider or via the center's vans, family oftentimes transports, sometimes individuals are within close proximity and don't need transportation, so it doesn't have to be provided, but it has to at least be arranged and coordinated by the center. So the question is, can you not provide it? So the answer is yes, if the individual doesn't need it. But it is a service that needs to be part of the CBAS, is part of the CBAS benefit, and you would not provide it at all if someone needed it.
This one Laura might be able to speak to. What was the outcome of having a standardized assessment tool during the waiver amendment? Isn't the standardized assessment tool still in the works?
This is the universal assessment tool that is a component authorized in statute under the Coordinated Care Initiative. And the CBAS is one of the programs that's included in that legislation. We've had an ongoing stakeholder process for the last year and a half in terms of looking at what would be a core set of assessment indices that would be used cutting across the in-home supportive services program, MSSP, and the CBAS program. We are time out. I mean, we are still a ways away, let me put it that way, from actually having a tool that's ready for broad dissemination. I think in early spring we'll have recommendations back to the stakeholder group, some testing of questions that might be included, but then really, more stakeholder involvement moving forward from that. So I think we're on parallel tracks here. I think as we look at person-centered care planning broadly, certainly within the framework that CMS has put out, there are elements, and I think that there's a lot of cross-fertilization between what that group's doing and what's being required both in the CBAS waiver as well as the other home, as well as the home and community-based waivers that we can draw from moving forward. But we need to be moving forward in terms of CBAS, in a parallel but coordinated track.
And this is Ed Long. In our discussions about universal assessment, we've had representatives from the CBAS community, and we've been very clear that within the CBAS setting, there are multiple assessments that are done in order to develop a plan of care that addresses an individual's needs. So the universal assessment is really being seen as less comprehensive than the full approach to assessments that's done in a CBAS center, but perhaps taking elements from the assessment that is done within the CBAS setting to assist such things as cross-program coordination.
And coordination with the health plan, because that
Right.
they are another, I mean, this is within the context of CCI, so they are also a very important member in this process in terms of doing interdisciplinary care planning and coordination.
Right.
So I think with that question, we're going to wrap it up today. There's many more questions that people have. We invite you, as always, to communicate with us via our Department of Aging's CBAS main email box there, and or call if you have some further questions. We fully expect, as we wade through these documents and see what made it into the final versions, that we're going to be seeking clarification with each other, and we're going to be sharing more information with all of you. So for today, as I said at the beginning, this is the beginning of the conversation. So for now, I hope that we provided some insights into what the document looks like and some of the things that we're going to be talking about and doing in the coming months. And again, a thank you from all of us to all of the folks who participated with us, some since back in October of 2013. It's been a long and tiring process, and we're happy that we finally have this approved document and we're moving forward. So thank you for participating today. We'll be talking more, and thanks for making the time.
And happy holidays, everybody.